to provide easy to remember guidance for BLS and AACLS resuscitation scenarios. The importance of early initiation of CPR by lay rescuers has been re-emphasized. Previous recommendations about epinephrine administration have been reaffirmed with emphasis on early epinephrine administration. Use of real-time audio-visual feedback is suggested as a mean to maintain CPR quality and optimization of the CPR. Continuous measurement of arterial BP and ETCO2 during ACLS resuscitation may be useful to improve CPR quality. Routine use of double sequential defibrillation is not recommended. IV access is the preferred route of medication administration during ACLS resuscitation. Intraosseous access can be acceptable if IV access is not available. Care of the patient after return of spontaneous circulation requires close attention to oxygenation, BP control, evaluation for percutaneous coronary intervention, targeted temperature management, and multimodal neuroprognostication. Because recovery from cardiac arrest continues long after the initial hospitalization, patients should have formal assessment and support for their physical, cognitive, and psychosocial needs. Cardiac arrest survivors and their caregivers should receive comprehensive multidisciplinary discharge planning to include medical and rehabilitative treatment, recommendations on return to activity, and work expectations. After a resuscitation, debriefing should be done for lay rescuers, emergency medical service providers, and hospital-based healthcare workers. It may be beneficial to support their mental health and well-being. Management of cardiac arrest in pregnancy focuses on maternal resuscitation with preparation for early perimortem cesarean delivery, if necessary, to save the infant and improve the chances of successful resuscitation of the mother. Because of potential interference with maternal resuscitation, fetal monitoring should not be undertaken during cardiac arrest in pregnancy. Targeted temperature monitoring is recommended for pregnant women who remain comatose after resuscitation from cardiac arrest. During targeted temperature monitoring, continuous fetal monitoring should be there to note down bradycardia as a potential complication, and obstetric and neonatal consultation should be sought. Changes in algorithms and visual aids. A sixth link, recovery link, was added to the in-hospital cardiac arrest and outside hospital cardiac arrest chains of survival. Universal adult cardiac arrest algorithm was modified to emphasize the role of early epinephrine administration for patients with non-shockable rhythm. 2 new opioid-associated emergency algorithms have been added for lay rescuers and trained rescuers. Post-cardiac arrest care algorithm was updated to emphasize the need to prevent hypoxia, hypoxemia, and hypotension. New diagram to guide and neuroprognostication has been added. A new cardiac arrest in pregnancy algorithm has been added. In case of pediatric BLS and CPR in infants and children and adolescents are combined with the pediatric ALS, causes of cardiac arrest in infants and children differ from cardiac arrest in adults. Algorithms and visual aids were revised to incorporate the best science and improve clarity for PBLS and pulse resuscitation providers. Rate of assisted ventilation has been increased to 1 breath every 2 to 3 seconds, that is 20 to 30 breaths per minute. And use of cuffed ET tubes are recommended to reduce air leak, and use of tube exchanges for patients of any age who require intubation. Routine use of cricoid pressure during intubation is no longer recommended. To maximize the chance of good resuscitation outcomes, epinephrine is administered as early as possible within 5 minutes of the start of cardiac arrest from non-shockable rhythm. The dose is 0.01 mg per kg IV. In case of ET tube, it is 0.1 mg per kg. With arterial line in situ, the feedback from continuous arterial BP monitoring may improve the CPR quality. After return of spontaneous circulation, we should evaluate for seizures. Both status epilepticus and any non-convulsive seizures should be treated with the expert opinion. Recovery from cardiac arrest. After recovery from cardiac arrest, formal assessment, physical, cognitive, and psychosocial needs should be sought. And titrated approach to the fluid management at 10 ml per kg. When with epinephrine or non-epinephrine infusions, if vasopressors are needed in case of septic shock. If epinephrine and norepinephrine are unavailable, dopamine infusion can also be started. Hemorrhagic shock should be treated with balanced blood component resuscitation. Children with acute myocarditis with arrhythmia, heart block, ST changes, with low cardiac output, there is increased risk of cardiac arrest. So the child should be transferred earlier to the ICU, and ECLS should be initiated.
Okay. Very good.
Infants. Yes,
Go
sir.
ahead.
Management of pulmonary hypertension should include the use of inhaled nitric oxide, prostacyclin, analgesia, sedation, neuromuscular blockade, induction of alkalosis, or a rescue therapy with ECLS. That's all, sir.
So, I don't know how many of you remember we had a discussion on